program tonight is webinar number 6 from our heart failure webinar series, drug protocol post-transplant. And MassGeneral Hospital has agreed to graciously share with us what their current general practices and protocol is for their management protocols. Before we get started, I just want to run through a couple things, basically, so everybody gets to know who we are. We're patients, just like you. We're traveling the heart failure journey. And after our transplant, we've decided to give back to our heart failure community. That's what Heart Brothers is. And our mission statement is to support heart failure patients and their loved ones navigating life with heart failure and all its challenges. I want to thank our sponsors, Transplant Corporation, CareDx, Cytokinetics, Abbott, and Novartis, because without their generosity and assistance, we would not be able to offer these to the community. Just want to follow quickly on various Heart Brother events. We have a monthly virtual patient support group on the second Thursday of every month at 6 p.m. Eastern time. It's open to everyone, anybody who's dealing with heart failure, regardless if you're just newly diagnosed, if you're with LVAD or transplant, it's open to all. We want to hear from everyone and sharing our stories and time. And we will have subject matter experts who will sit there and just on a very personal, close-knit setting, answer your questions. We have webinars focused on heart failure. This is number 6 in those webinar series. And then on August 1st, we have our Mike Gustin Memorial Golf Classic. We'll have one next year. And in this year, November 20th through the 27th, which ending today, we have our 3rd annual Member for a Day golf auction, where you can bid to go play in a threesome or foursome in some pretty exclusive golf clubs around the country. On November 6th, which is our next webinar, we're going to have a webinar on post-transplant care. And we're going to be joined in that webinar with CareDx. And on December 6th, 7th, and 8th, we're going to have our 8th annual Team Heart Brothers Symposium. And that's it. So just a quick disclaimer. While today's participants are medical professionals and are licensed and qualified to practice medicine, should always seek the advice of your own physician or medical team with any questions you may have regarding your specific medical condition. The information shared today is not intended or implied to be a substitute for professional medical advice from your own healthcare provider. So some virtual meeting best practices. For higher quality viewing, choose the full screen in the upper right corner. To make comments, utilize the chat in the bottom navigation. Then select all panelists and attendees from the drop-down. And to ask questions, utilize the Q&A function in the bottom of the navigation panel. So a quick introduction. Our featured speaker is Dr. Greg Lewis from MassGeneral Hospital, and our moderator, who's Glenn Rockwood, will get into a detailed introduction of the speakers and the panelists. But Glenn himself, he received his OCS heart transplant in Massachusetts General Hospital on February of 2017 at the age of 62. He had been an active volunteer with Team Heart Brothers for several years, is on the board of the American Heart Association, and participates in the annual Capital Region Heart Walk and run for the University of Albany. Glenn, thank you very much for being here and for agreeing to help us. The other panelist is Megan Doucette. She had a master's in nursing, and Glenn will again introduce her, and same with Dr. Georgiana Waldman. She's a pharmacist, pharmacy doctor, and also from MGH. And Glenn will share a quick bio on all of those.
Okay.
And Glenn, with that, I'm going to turn it over to you.
Okay. Thanks very much.
And I'm going to stop sharing my screen.
Okay. All right, again, welcome to our panelists today. Dr. Lewis is a cardiologist and an associate professor of medicine at Harvard Medical School. He's the medical director of the Heart Transplant Program, director of the Cardiopulmonary Exercise Laboratory, and section head of the heart failure at Massachusetts General Hospital. Dr. Lewis received his Bachelor's of Arts degree in biochemistry and molecular biology from Dartmouth College and his MD from the University of Rochester School of Medicine. He's earned a Master's of Science degree in medical science from the Harvard Medical MIT program, Harvard MIT program in health sciences and technologies. He's completed his residency in internal medicine at Massachusetts General Hospital, followed by clinical and research fellowships in cardiology at Massachusetts General Hospital. He joined the staff of Massachusetts General Hospital as a staff member of the Division of Cardiology. Dr. Lewis's clinical practice is focused on delivering care to patients with a broad range of cardiovascular diseases, while also leading patient-oriented research initiatives aimed at improving functional capacity and prognosis in patients with heart failure. As an investigator at MGH, he has published numerous manuscripts in fields ranging from the evaluation of novel therapies for heart failure to mechanisms of exercise intolerance and cardiovascular disease. Again, welcome, Dr. Lewis, and thank you for participating today. Megan Doucette is the lead advanced practice provider for Massachusetts General Hospital in the cardiac transplant program. She received her bachelor's degree in nursing from the University of Massachusetts Amherst and her master's degree from Simmons University. She's been with Mass General since 2020 and has helped update various immunosuppression protocols since then. She has a passion for advancing health equity in heart transplant. Thank you, Megan, for joining us today. And Dr. Georgiana Waldman is currently a clinical pharmacy specialist in cardiothoracic transplant at Mass General Hospital. She received her doctor's of pharmacy degree from the University of Pittsburgh and completed her PGY1 pharmacy practice residency and PGY2 solid organ transplantation residency at UC San Diego Health. Her current research and interests include opportunistic infections, multi-organ transplant, and patient individualized optimization of immunosuppression. Dr. Waldman, thank you for participating today as well. So we'll get right into it. If Dr. Lewis wants to get started, and then we'll follow that with Megan and then Dr. Waldman, and after that we'll have a question and answer period. So enjoy.
Thank you, Glenn, for the kind introduction. I'm going to share my screen here. Get the slides up. Can people see my first slide okay, saying current MGH program management protocols?
Very good.
Okay, great. So before getting started with this presentation, and all three of us will be presenting briefly this evening, I want to take a moment to express our gratitude to the Hart brothers for everything that they do to help our patients. Been incredibly helpful in terms of the journeys that our patients are on at MGH. And you know, there has been numerous occasions in which the Hart brothers have really stepped in and played a critically important role in the ongoing health status and well-being of our patients. So we're incredibly grateful in that regard. So when Glenn asked us to present this evening, said I'd be more than happy to do so. And we very much are a team approach here. So there's three speakers tonight, and we'll all take different parts of our presentation. I wanted to start before we get into the specific management protocols or drug protocols, just by talking about how do we get patients to transplant in the first place, and how do things look right now in the region, in the country, in the world, and what are we doing to get more patients kind of over that initial important line. I won't call it a finish line, so that they can become post-transplant patients and then be managed in the various programs in the region. So we know heart failure is a tremendous burden. All of the people on this call know this very well, but the statistics show that it's just going to continue to increase in terms of its prevalence. There's over 1 million annual hospitalizations for heart failure. We take care of over 1,400 patients primarily admitted for the diagnosis of heart failure at MGH each year. It's the leading reason to come into the hospital for those over the age of 65. Unfortunately, disproportionately impacts Black Americans more than other groups. And it comes at an enormous cost in terms of looking at the amount of expenditure on the care of heart failure, which equates, as of 2030, will be about $250 per U.S. citizen. And many of you are also very familiar with this slide in terms of thinking about, how does heart failure then distribute beyond the totality of people that are living with heart failure. And we know if we drill down on those that are most symptomatic with severe heart failure, we still have about 200,000 individuals in the country. And if we look at the rate at which there's an ascent in heart transplantation, we see that the volumes have been relatively flat. This slide requires more contemporary data, but it really hasn't changed a whole lot. So at the same time that we have a markedly increasing burden of heart failure in society, we have a relatively flat curve in terms of the number of transplants being done. And as a result, if we look back in the early 1990s, about 1 in every 1,000 people that were highly symptomatic below the age of 75 with heart failure would be able to get a transplant. And then as we project forward to the current era, it's less than 1 in 2,000, and it's going to be even more of a mismatch as we proceed forward in terms of our burden of heart failure at a societal level. So how are we doing in our region? Again, I realize these are statistics that many of you will be familiar with. I wanted to start with the region. I recognize that members of the Heart Brothers are, one of the great things you do is you seem to be, quite inclusive in terms of the different programs in the region. So to put this into perspective, this is the last 20 years of heart transplantation. So I will, argue that we have grown disproportionately to the totality of transplants being done nationally and internationally here in Massachusetts. So you can see in the early 2000s, there was roughly about 50 transplants being done annually in the region. And if we look, there's been some impact of COVID, and when you look at 2020, 2021 in terms of our trajectory, but we've really done a nice job of going, say, from the 50s up to the 100, 110 transplants a year. So roughly doubling if we look over this period of the last 20 years for the number of heart transplants performed among programs here in Massachusetts. And importantly, while we certainly wish that we could take care of everybody's native hearts in a way that they would never need a heart transplant, I think the people on this call can attest to when you really need a heart transplant, it's good to be in a place where you can actually get one. So in Massachusetts, there's 1 transplant performed for every roughly 4,500 individuals. About 2% of the population has heart failure, but 1 in every 4,500 individuals living in Massachusetts gets a heart transplant based on current population statistics. If we compare that to worldwide heart transplant availability, there's less than 1 transplant per million individuals. So I think we're fortunate to be in the state of Massachusetts, where we've have some fantastic medical centers. Certainly for any of you that are from the Connecticut or other areas of New England can attest to this as well. And clearly we draw from patients that are from out of state, but by way of illustration, the density of heart transplantation is much greater here than it is in other parts of the world. And also importantly, I think that we oftentimes hear about things that we could be doing better as a country and as a society here. Heart transplant's one of the things that we're doing relatively well at. If you look in the middle at North America, which is dominated by programs here in the US, and you look at 1-year survival after transplant in these different eras, the early 2000s to 2006 to 2011, and then 2012 to 2017, you can see that in the US and in North America, at the 1-year point after a heart transplant, there's a 90% plus survival right now. If we look across Europe and across other parts of the country, there's about an 80% survival at the 1-year mark. So again, the US is doing a good job in terms of the care of patients post-heart transplant. And then here's some more specific data just in terms of the last 50 years of heart transplantation. I showed some program-specific data here in terms of our particular program at MGH, where dating all the way back to the 1980s, we've seen a big surge of about a 3- to 4-fold increase in our volume in recent years, which puts us up among the highest volume programs here in the US. And so, how do we get more patients into these protocols that Megan and Georgina are going to walk you through here at MGH? One way is by being aggressive in terms of trying to find appropriate donor hearts for our patients that are awaiting heart transplantation. And so, if we look at some of these strategies, I'm just going to briefly walk through them, and then we'll have a chance to talk about them in the Q&A session. First is how to support patients going into transplant. This is a bit of a busy slide, but I'll draw your attention to this lower curve here, and that is patients that are on extracorporeal membrane oxygenation support devices tend to be very, very ill. They're favored in the current strategy of the different listing tiers for the post-2018 listing strata. But what we found in our program is that if you can support patients with mechanical pumps, it tends to bode better for them in terms of the use of biventricular support devices for temporary support rather than ECMO in terms of how patients do in the long term. So we do use a lot of devices here at MGH to keep our patients as well as possible prior to their transplant. And in doing so, our physical therapists, our occupational therapists, our nurses are wonderful in terms of trying to keep patients ambulatory while they're undergoing BiV support. And then over the course of the last 5 years, one of the reasons that we're performing as many transplants as we are is because we've been very aggressive with trying to expand the donor pool. And this, this relates to our program, but it also relates to programs all across the country in terms of trying to use as many hearts as we possibly can safely for our patients. And so we've adopted a protocol with the help of our hospital, which I'm quite grateful to, by supplying a dose of anti-Hep C medication to patients, not after we know what their genotype of the hepatitis C virus is or what we know what their viral load is, but actually before they even get the heart transplant. So we adopted this protocol a number of years ago, where when patients are being sent down to the operating room and we accept a heart from a hepatitis C positive donor, we give the anti-hepatitis C medicine to the patient so it's in their system at the time that the heart goes in. This makes a tremendous difference in terms of the amount of Hep C virus that the recipient ever sees. And we see extremely low levels of the virus, if any at all, in the patients. And we've seen none of the patients become sick with hepatitis C as a result. And the medicine is Mavorite, which Georgina has played a significant role in implementing our protocols here. Unfortunately, when we rolled this out, we found these patients were doing very well. They were getting these young hearts that were otherwise being discarded. And we were able to transplant patients very quickly and see very good outcomes with the hepatitis C hearts. This is our waiting times in the right here. Patients were waiting on average about 7 days when we started this protocol for the Hep C hearts. Some of you we heard about the organ care system. Initially, some of you are very familiar with this in terms of how to support and reanimate hearts. This is something that our surgeons, led by Dave D'Alessandro, have played a leadership role in. in terms of using a device to, rather than to have the heart be in a cooler when it's being transported, to essentially reanimate the heart and to keep it nourished with the donor's own blood supply while the heart is en route to the recipient. And for this, we've begun doing donation after circulatory death heart transplantation here at MGH, almost a mirror image of the hepatitis C protocol. When we started utilizing donation after circulatory death hearts, patients were waiting for about a week for their heart transplant. And this trial was done across about a little over 100 patients. At Duke and MGH were the leaders in terms of enrollment in this trial. And what we found is that in the very beginning of their experience here at MGH with performing this type of a heart transplant, there was more support needed for the hearts right after the heart transplant. But then as we gain more experience with them and we look at our first 13 patients, or second 13, or third 13, the need for supporting the hearts right after the transplant got less and less over time. And so what we just wrote up our experience here in terms of the two different strategies to transplant hearts. After brain death, which is a traditional strategy for which most people have received their heart transplant, and then after circulatory death, where we do this reanimation approach with the OCS device. And similar to the Hep C protocol, our DCD hearts were, if anything, they were performing as well or better with a 0% 6-month mortality here. So more and more programs are also adopting the DCD strategy. We have found that the right side of the heart temporarily has more trouble than the left side of the heart after performing this type of heart transplantation. But by the time patients are out 3 weeks from the transplant, the performance of the hearts are identical. And we've seen uniform normalization of heart function by the time we do their echocardiograms at the 1-month point post-transplant. So this is a strategy that is here to stay, and it's going to expand the donor pool by more than 30% in terms of heart transplants for patients waiting. Just some more information about the patients in terms of the amount of blood that the heart pumps is the same as those that had donation after brain death. The pressures by week 4 are identical. The ejection fractions are identical, and the rates of rejection are similar between the DCD and the DBD hearts. So that I've kind of very briefly walked through strategies to do more heart transplants. I don't know if you've had maybe Glenn, you can tell me if you've already had a session with the Hart brothers on xenotransplantation.
We have not familiar with that at all. Okay.
All right. Well, just in terms of this audience, I think I'm just going to spend a couple of minutes on this, and then we'll transition over to Megan and to Georgina. So I've mentioned some exciting areas of advance in heart transplantation that I think are going to afford more people the chance to get hearts. As of this year, in January 7th, there was a first ever use of a pig heart into a human, which is the definition of xenotransplantation, in a 57-year-old gentleman who was deemed by the University of Maryland program, as well as several other programs, to unfortunately not be a candidate for a heart transplant. The patient was being supported on an ECMO circuit and was willing to essentially take this chance that was otherwise not going to be afforded to him by virtue of having this this xenotransplantation. And so what was used was essentially a gene-edited, 10 gene edits pig donor, where there was specific edits to the genes to make the heart the right size for a human being. These pigs are 400 pounds from which the hearts are being essentially grown. And then there was a very special strategy used using this anti-CD40 monoclonal antibody as a way of immunosuppressing the patient, in addition to the immunosuppressants that many of you on the call are very familiar with. And just like the system that I just showed you, there was an ex vivo heart perfusion system used in this case. And Dr. Griffith profiled this experience at a meeting at the ISHLT meetings, and it was a really special time and a potential significant advance to hear about, with significant involvement of members of our team. Dr. Pearson here at MGH worked on a lot of the edits of these genes in order to make the heart compatible with a human being. And Dr. Fishman from our infectious disease team was advising the patients on potential infections that can come from pigs to humans throughout the course of this patient. So this gentleman underwent the transplantation and for 4 additional days remained on the support circuit. And then the heart was actually beating very vigorously within the patient, such that they were able to remove the ECMO circuit, and the heart was sustaining the patient completely on their own. This is kind of a busy slide, but shown here in blue is the ejection fraction, which was in excess of 50% throughout the course with the xenotransplantation. And they followed markers like of heart injury, like the troponin, and that was nicely coming down after the transplant. And they looked at the thickness of the walls of the heart, and really things were off to a quite a good start for this patient in terms of the way in which this heart was sustaining the patient. However, the patient at day 20 started to show signs of cytomegalovirus, which some of you may be familiar in terms of the human form of cytomegalovirus. And this was identified in the recipient, but of course this was a porcine pig form of the CMV. And this was what Dr. Fishman was advising them on in terms of how to manage this infection. But like infections in our human transplant recipients with human hearts, the next step was to decrement the immunosuppression in order to try to clear this infection. And so the mycophenolate that the patient was taking was stopped. The white blood cell count plummeted, as it sometimes does with CMV infections. And so there was support mechanisms to try to bolster the white blood cell production. A biopsy was performed here, and at this point, at day 34, the heart was pumping, with an ejection fraction over 60% here. The walls of the heart were appropriate in terms of their thickness, and the patient was being supported by this porcine heart. And then as things progressed into the second month with the heart transplant, the patient began to show signs of rejection in the heart. The size of the heart began to increase. The troponin levels, which are a marker of heart injury, began to increase. And they began to give plasma exchange and various treatments to try to quell the immune response to the porcine heart. And so unfortunately, by day 60, the patient had progressive dysfunction of the heart and had to have withdrawal of life support. So clearly not a long-term success, but honestly something that was 60 days of heart transplantation had never been done before, and a indicator of progress in this field. Clearly, there's a lot more work to be done, but is a reflection as well of some of the innovative thinking that's going on in this field, with additional work that's needed in order to make this viable for more patients. So I'll stop there, and I can turn things over to Megan. We can take questions at the end. We can take questions now. Either way is fine with me.
Oh, we'll hold them till the end. Let's proceed with the program. That's very interesting. But Megan?
Thank you. So thanks everyone for having me tonight. I'm Megan Doucette, one of the nurse practitioners with the MGH team. Give me a second to put this up. All right. So a little bit of a transition from what Dr. Lewis was talking about, but obviously you're all aware that heart transplant is a team sport. So there's a lot of players with the center of that being our transplant recipients and their caregivers. At MGH, we're really proud that we've been able to expand our team even over the past couple of years due to our growing program. So you can see the numbers of people here, and this obviously is not a totally inclusive list of everyone that's involved in the transplant process and working to improve efficiencies along the way, pre-transplant, in the hospital, immediately post-transplant, and then kind of long-term. So I can't go without acknowledging everyone that's part of this process. One big thing that we're really proud of at MGH is the improvement in our biopsy protocol. Just a few years ago, patients were getting, 17 biopsies within the first couple of years, and then it dropped down to about 10. And now we have this updated protocol that rolled out at the end of last year. And we've kind of customized these pathways as a high immunologic risk versus low immunologic risk pathways, where we're really cutting back on the number of biopsies. As you're all aware, they're not benign procedures. They give us great information about rejection status, but come with some potential side effects and consequences. We're using the AlloMap or CareDx lab tests, as well as some other blood work that some of you might be familiar with to help guide our biopsy protocols as well. And, certainly there are patients who qualify for one versus the other or might jump between these two, but so far this year, we're coming up on almost a year since we implemented this protocol, that we've had some really good success with it, and we're really excited. And, for patients who went through the old protocols, I'm sure this is something really exciting to see an evolution of this process. And we hope that, with the improvement in some of the blood technology that's out there, in the next couple of years, even these numbers can decrease over time. But ultimately, it's really important to note, and Georgina will jump into the medication portion of this, that the immunosuppression regimen is really tailored to the individual patient. That's a big thing that we have here. Although we have these, our protocols, we have to think about individual patients. And so there's no one size fits all. So understanding, what challenges might be going on with the patient, that's what we're looking at, the whole picture. So I'll let Georgina kind of take over from here about some of our more specific drug protocols that we have going on.
All right, thank you so much for that wonderful transition, Megan. So to start off with, you will notice that Megan introduced really nicely that the name of our game is personalized medicine. Protocols are wonderful for developing our initial guidance and making sure that we have a uniform practice across the board. However, for example, using this image on the right, you can see that when one size fits all is applied to every patient, there will be some patients who do extremely well with therapy and other patients who may struggle with adverse effects and how their body manages the medication. So we have developed several complex decision pathways highlighted just recently with Megan's slide, where you can see we have the high immunologic risk, low immunologic risk, characterizations that put patients into one group versus the other, as well as reasons why they may have to switch back and forth. So these are all patient-specific factors that we use to optimize the medical therapy for each patient. So with our goal being to improve our patient outcomes, prevent that rejection, make sure that patients are integrating their medications into their daily routine while minimizing adverse effects. So as you're familiar, there's a lot of options within the class of medications that we use to prevent acute cellular rejection. And I say the most important thing after a transplant to keep your heart healthy and keep functioning well is the medications. Up front, we'll customize whether we use induction therapies, which are strong, potent immunosuppression, right at the time of transplant. If a patient is considered to be high immunologic risk or have a strong immune system, we'll use some of these therapies that you may have heard of anti-thymocyte globulin or thymo, basiliximab, or corticosteroids. After the transplant, we maintain on maintenance immunosuppression because although the body has the heart for the rest of the time, and the immune system never quite gets used to having that new heart in your body. So we use 3 medications as our backbone to prevent the acute cellular rejection. Our calcineurin inhibitors, so patients are either on tacrolimus or cyclosporin, cell cycle inhibitors, which includes mycophenolate or azathioprine, as well as our steroids. Some patients may also be maintained in the long term once they're outside of that initial heart transplant period on a class of medications called mTOR inhibitors, which include your sirolimus or everolimus. So getting into high versus low immunologic risk, what does that mean? Just so you can kind of have a sense, it depends on what brought you to transplant and what phase of transplant you are. Now that we're transplanting patients who are older, honestly, one of our protocols has been to raise the ceiling for that cutoff of age. Those patients have a lower immunologic risk because they have weaker immune systems in general. Patients with a history of cancer or significant infectious history, or even patients who have already received another transplant, perhaps they're getting retransplanted. Those are patients that we consider our low immunologic risk, and those are patients that we actually target for a rapid steroid withdrawal. Our high immunologic risk patients are patients who may be younger and have an autoimmune indication for needing a transplant, patients who are sensitized, which means that even before the transplant, their body has developed antibodies to potential other donors, including, say, through blood transfusions or women who've had pregnancies, as well as patients who may not be able to tolerate some immunosuppression agents as well. We have to optimize their other medications to make sure that they are still well protected against rejection. One of the ways we do this is by optimizing our formulations of tacrolimus. Tacrolimus is our gold star therapy after transplant and is most commonly used, you most likely be familiar with, our immediate release formulation, which is taken twice a day, 12 hours apart. However, there's also an extended release formulation that for some patients who their genome, their pharmacogenomics just shows that they're a rapid metabolizer. And this is really nicely shown in the graph on the right. So patients who get these formulations are a situation where some patients rapidly clear their tacrolimus, which means that when they're on the immediate release formulation, though they're on high doses of this medication, their levels are still pretty low. But they might be noticing more toxicity and more side effects because they're still getting the same peak of the medications, the same peak concentration, which is associated with things like those tremors and headaches that you might be familiar with. But they clear it so quickly that when we monitor their troughs that assess for the efficacy of the medication, they're still low. So we have to go higher and higher. One of the nice ways for the medication Varsis, which is an extended release formulation, and you can see is absorbed all throughout the GI tract. You can see that this patient on the graph in the blue line notes the Varsis formulation, where though they still get higher concentrate, their troughs are still the same at that 24-hour mark. They have a delayed peak and 30% smaller peak compared to the immediate release formulations, which is a real benefit for some patients and patients who might be experiencing significant tremors or headaches on high doses of tacrolimus, maybe because you're a CYP3A5 rapid metabolizer. Some of you may be familiar with cyclosporin as well. I will say, I hope that everybody on this call or listening in is on cyclosporin modified, as opposed to the original cyclosporin that was developed in the 80s, which has much more erratic absorption, where in the graph below, you can see the modified as the top line has a more consistent exposure as compared to the unmodified formulation. So always good to double check and make sure when you pick that up from your pharmacy that you are still getting the cyclosporin modified formulation, as they are not interchangeable. But what is the difference between these calcineurin inhibitors, and why might we switch a patient from tacrolimus to cyclosporin? One of the big things is side effects. Tacrolimus is associated with more neurotoxicity, including tremors and headaches, as well as high blood sugars. Whereas cyclosporin, interestingly, has some of the opposite side effects where there's more higher lipids associated with cyclosporin. This cyclosporin will make your hair grow, whereas tacrolimus will make you lose your hair. Interesting aspects of the cousin drugs, but it's important to notice the difference and something we're balancing when we're switching patients between the agents. Another way at MGH that we personalize medication for our patients is actually looking at the dose of Lovenox, which is a blood thinner that we'll sometimes need to use when patients have had a clot after their transplant. Given the frequent number of biopsies, that's a procedure that puts you at risk for bleeding. We like Lovenox because it can quickly be discontinued. The manufacturer actually recommends a higher dose at 1 milligram per kilogram every 12 hours at standard dosing for patients with clots. However, through monitoring, we found this led to an increased higher risk for bleeding. And our retrospective analysis actually found that a significantly reduced dose of 0.6 milligrams per kilogram every 12 hours was optimal for balancing risk and benefit for our heart transplant patients. And this is something that we've let the lead on with this retrospective review. Can't be a pharmacist talking about how an ounce of prevention is worth a pound of cure. We have these medications on board to prevent you from getting rejection. And one non-adherence to your medications is a primary driver of rejection, acute cellular rejection, as well as antibody-mediated rejection, which is in the longer term. So that's why we want to ensure you have access to your medications and are tolerating them well. And these non-adherence has a high cost. This data is from the kidney transplant world, but it's applicable to our heart transplant patients as well, where it can be, it's associated with decreased 5-year survival if patients are non-adherent, increased medical complications and need for retransplant, as well as an increased need for healthcare utilization. Rejection is a significant problem that we always are trying to modify our approach and assess it. Since we're doing that frequent monitoring of the biopsies, this actually allows us to catch rejection before it becomes a very significant problem leading to graft loss. So we actually did a retrospective review of our own treatments of rejection, specifically focusing on those 2R rejections, which are those moderate rejections on the scale. And we actually found that with looking at all of our different dosing of and approaches to rejection, as well as assessing the subsequent rejection episode, we found that we were able to optimize a lower steroid dosing as compared to some high pulse doses of prednisone that required hospitalizations. We were actually able to transition to an outpatient treatment regimen without an impact on these the subsequent biopsies as noted here. Dr. Lewis and one of our wonderful fellows have also done some incredible work on the impacts of these rejections noted on biopsies on the patient's heart function as well in conjunction with this retrospective review. And we found when we were even using these lower doses of the steroids, we were not seeing a significant hemodynamic impact on the heart function, therefore allowing us to get away with lower doses of steroids, preventing hospitalizations, as well as reducing side effects from some of these steroids. And lastly, we can't talk about immunosuppression without talking about that infectious risk after transplant. This infectious risk is evolving after transplant. You can see that early in the post-transplant period, there's high amounts of immunosuppression. So donor-derived infections, wound infections from the surgeries are most predominant. However, as we're doing that dose finding of our maintenance immunosuppression and induction is wearing off, there can be activation of those opportunistic infections. It happened even earlier in that xenotransplant patient that Dr. Lewis was referencing earlier. And then finally, being on maintenance immunosuppression does put you at increased risk for community-acquired infections. So those are things that we're always keeping on the back of our minds and always assessing. Within our MGH protocol, we take a more aggressive approach, specifically in the antifungal approach for medication. So though there's 3 different tiers we typically think of are antibiotics, antivirals, and antifungal medications. Our antifungal medications is where at MassGeneral, we use a medication called posaconazole or isobuconazonium to prevent fungal infections in the first 3 months post-transplant. With this is a strong CYP3A4 inhibitor, which means that it doesn't play nicely with the tacrolimus So we actually reviewed our management of the drug interaction at discontinuation, and we found that this allowed us to optimize and modify our protocol so that we're checking your tacrolimus levels at the appropriate times to prevent you from getting too low on your tacrolimus and increasing your risk for rejection. We actually found that 3-week mark. We originally thought it would be the first 2 weeks based on the kinetics of the medication, but we actually found that 3-week mark to really be one of the high-risk patient areas, and are more aggressive in our dose titration at that point because of it. And lastly, I'm going to focus on the hepatitis C that Dr. Lewis gave some great background on our protocols here. Various centers will take various approaches to using the hepatitis C therapies to prevent transmission or to treat the hepatitis C that was acquired from the donor. At Massachusetts General, we use which is glecaprevir preventasphere. Look at it at the top. If you've ever used it, you'll recognize the wallet with the 3 tablets that you take every day. And we actually start our timing at the time of transplant, as Dr. Lewis mentioned, which is very aggressive and actually has led to some pretty impressive outcomes. Majority of centers are not able to afford starting this medication within formulary, given that these medications, of course, cost about $24,000. But we are able to start it right at the time of transplant, which almost prevents some of that transmission of their medication, of the virus. These are very effective medications, and the duration is actually something that people are looking at more closely to try to attempt shorter and shorter courses with the same effectiveness. At Mass General, one of the restrictions to patients and centers using Mavorite previously at that time post-transplant is that there are no data surrounding the administration of Mavorite when patients were unable to swallow the tablets whole in that early postoperative period. However, we looked at our data showing that there was no difference in time to clearance of viral load when we were crushing the tablets for our patients who maybe were intubated for a longer time or were unable to swallow the tablets in that early postoperative period. And with that, I'm going to leave you with a final reminder, open it up for a bit of time for questions. Please communicate with your transplant center. We can't help if we don't know what's going on, but taking your medications correctly is the best thing you can do to help with your long-term survival. Not all medications play nicely together, so please consult your transplant team before starting anything new. And with that, I would like to open it up to any questions.
Okay. All 3 of you, that was very informative. All right, Hamid, go ahead. You're first.
Okay, so the discussion of immunosuppressants and food. Okay, so and there's a lot of anecdotal data out there, and I have a specific food in mind. But before we get to that, is there any interaction between specific foods and immunosuppressants?
I'm happy to take this one. Yes, there certainly is, and things are certainly important to be aware of. That SIP that I mentioned is how the medication is cleared from your body. So when you have certain foods or medications that affect those CYP3A4 enzymes, such as grapefruit juice, grapefruit being one of the common ones, it will actually affect the levels of your medications. Unfortunately, we actually recommend avoiding these foods because it's not even like you could take a grapefruit a day and have consistent exposure to the to this enzyme. Every grapefruit has a different amount of this enzyme, and that's actually been shown in some studies as well. So it's not, I can't even tell you to have a glass of grapefruit juice a day, like when patients are on warfarin, where we can say you can have leafy greens, but just eat a salad every day. So unfortunately, there's not consistency from that perspective. Pomegranates are another one that will come up as a more rare one, as well as star fruit, are some of the CYP3A4 medications. Although I will say, in terms of some good news coming out of some recent data that was just published at the American Transplant Congress, the Envarsus formulation of tacrolimus that I mentioned actually had a significantly less impact from grapefruit because of the medication being absorbed further down and bypassing some of that CYP3A5 metabolism. It also seems to bypass some of that CYP3A4 effect. So you have less impact in the Envarsus formulations, but I'd still stay away from it. The data is still pretty new.
My interest was a pomegranate, which you touched on. So I guess that's a no-no.
Yes, I would, what I say is, you know, a few pomegranate seeds here and then is not a huge exposure, and like, you know, consuming a whole grapefruit, but some of those concentrated pomegranate juices, things like that. They seem to sneak it into a lot of things.
Okay, thank you.
Okay, I have a couple questions. I don't see any questions coming up just yet, but your statistics, Dr. Lewis, were from 2017 and previous. You have nothing more recent than that? And how long does it take typically to publish that newer data?
Well, so there's always a trailing reporting, because if you want to follow people over time, right, you need the time for the outcomes to accrue afterwards. So that data is actually from the most recent statistical data published by UNO. So typically right around this time of year, we'll see the next iteration of the data, and that'll just march forward by 1 year. So it's
typically 4 to 5 years.
There's a lag time. For example, after we transitioned in 2018 to a new allocation system with the 7 tiers instead of 3, there was the whole community was very eager to see what the ramifications of that switch would be, but we needed to wait, a couple of years even to get that first, 6-month data to come out. So there's always going to be a lag in terms of the outcomes data.
Okay. Then you had mentioned also that something was plus 30, but it seems like even though we're getting more hearts now between the hepatitis C and the DCD hearts, it's still based on your escalation of the need over the next 15 years, we're still not really going to catch up. So this work with the xenotransplant seems to be extremely important if we're ever going to bridge that gap, is what it seems to me. I've been thinking over the last 3 to 5 years that the addition of the Hep C hearts and the DCD hearts and the approval of the transmedic organ care system, that things were going to take a turn the other way, and we would at some point in my fantasy world, we'd have hearts on a shelf someplace just waiting for somebody that needed one. You'd be able to not go to Walmart necessarily, but you know what I mean. You'd have access to hearts that weren't spoken for ahead of time, and that doesn't seem like it's going to be the case anytime soon.
Yeah, Glenn, thanks for the question. It's one of those things that when if you do something that represents kind of an innovation, then of course the early adopters can really benefit from that, because you have this availability that you didn't have before. Mm-hmm. But then, appropriately so, other programs will adopt similar strategies, and then then things kind of level out only to the increment that's, afforded by the new approach, right? And so the 30% I was mentioning was for the donation after circulatory death hearts, where we think about 30 to 35% of the donors that become available are in that category. And previously, those hearts were not being used at all. Right. So that is a substantial improvement compared to where we were before. And you can imagine, if you're right at the beginning of it, it becomes very big difference. But it's going to be incorporated as basically about a 30% improvement in the total number of organs available. So it is going to increase the number of transplants done here in the U.S. And obviously that's a really good thing for our patients. But yes, one of the reasons for showing the first slide is to say that it's not going to keep pace with the number of people, unfortunately, that are suffering from heart failure. Right. Now, at the same time as these advances are taking place, there are continuing to be advances in the care of patients with heart failure. And we are seeing more and more heart failure go into remission, if you will. We don't want to say that it's gone away, but with all the different combination pharmacotherapies, device therapies, there's been a real big uptick in both. Then we are seeing more hearts with severe pumping dysfunction undergo normalization.
That's good. So we have a question that came in from one of our co-founders, Bob Romer, and his question is, tacrolimus seems to be a norm. Is that changing?
Georgina, you want to start?
Yeah, I would say not anytime soon. I think that our calcineurin inhibitors have really been proven time and time again to be one of our strongest and best backbones of immunosuppression. We often, when we're looking at the next step in immunosuppression, we look towards the kidney transplant literature, given that there are more kidney transplants, as well as the fact that if a graft fails, they have the option of participating on dialysis and staying alive, as opposed to the higher risk with our heart and lung transplant patients. They get to be a little bit more innovative. Another medication that might be coming down the line is belatacept, which is an IV infusion, and sometimes will replace calcineurin inhibition in our kidney transplant patients. However, it's very early experience in the heart transplant population and is tough because you can't customize it enough. It's an infusion that lasts you for 30 days. But unlike if you get an infection in that time, you're not able to reduce the dose as quickly, and we're able to react with your immunosuppression like tacrolimus. The formulations of tacrolimus seem to be advancing in terms of the Envarsus and expanding the use of that as a hopefully more tolerable formulation of the calcineurin inhibition, but I don't see it going away anytime soon.
Okay. I had another question about, I don't see any other questions coming in, but left versus the right ventricle on the hardening. Why does the left seem to fail more than the right? Did I get that correct?
Glenn, are you referring to the donation after circulatory death hearts, or
yeah,
are you
yes.
just generally speaking? Yeah.
Yeah.
You know, our goal, honestly, with performing these donation after circulatory death hearts was to understand as much as we possibly could about them, you know, what unique challenges that they may pose. And so that's what prompted us to look at very carefully, where we basically just took the first 50 donation after circulatory death hearts that we transplanted, and then compared them to, you know, the last 100 or so hearts that we'd done with the traditional approach. And so we looked at all kinds of different things. You know, we looked at echocardiogram features. We looked at whether one, you know, type of approach led more rejection than the other. We looked at, you know, whether or not they needed more medicine in the intensive care unit. And what we found, you know, that came out was this signal about the right side of the heart. And, you know, there's various different reasons why that may be the case. One is just the OCS machine, where you're really supporting the heart and you're loading the heart on the left side during that reanimation process and during the preservation process, and you're not doing the same for the right side of the heart. And so, you know, that may be one reason why the right side of the heart does seem to struggle more. We didn't see any differences in terms of like what the patients looked like going in. It wasn't like one of the patients had more resistance in their pulmonary circulation than the other group of patients. So it may very well have to do with the, you know, with the methodology of how the heart is, you know, is procured. And what we find is that the biggest differences is that first week when we measure the pressures in all the patients. And then by the second time the right heart cath is done and the biopsy, the differences are attenuated. And by week 3, we see that they essentially have almost identical performance. So we think this is temporary. And when we see something like this, there's strategies that we can deploy. You know, we can use certain medicines to reduce the load on the right side of the heart, and while patients are in the intensive care unit, we can support the heart with certain, you know, inotropic agents and things like that. So it'll, you know, our goal is to provide that knowledge to all the other centers that are adopting this approach, so that they can be mindful of supporting the right side of the heart.
Okay. All right. I don't see any other questions. It's 6:31. So I guess I'll say thank you. Oh, wait a minute. A question just came in. I just completed my second annual. This came from Debbie. Still here and doing well. I guess that means they must be there. Okay. Thank you for your care when I was there, and also for this info. The more we know about our meds and general care, the better we are all going to be, continue to be. So I guess there's no question there. It's just a thank you.
Hi, Debbie. Good to see you.
Glad you're doing well.
Glad to hear you're doing so well.
All right. Well, you have another question?
No, Debbie.
Yeah, I wanted to get, and I think we need to take advantage of this team and have another one just on xenotransplantation, because I just was fascinated by it. But there's many questions I have, but Do you believe if it wasn't for the CMV and having to adjust the immunosuppressant dose that the patient would have probably done better?
Yeah, thanks for the question. And I do think, I think it would be terrific to host a series on this. And honestly, there are people out there that are much more expert in this area of xenotransplantation than I am, particularly our own Robin Pearson, who's here at MGH, who's really dedicated his career to seeing this become a reality. And Robin was actually at the University of Maryland for many years doing a lot of the seminal work that made this possible before relocating to MGH, with a goal, frankly, to start a xenotransplantation program here. So it would be great to have Robin come to speak with all of you about all the work that's gone into this. I think, we obviously want to recognize, first and foremost, this is for the recipient, this was his, life that was basically in the hands of this transplantation, and that he, survived for only 60 days. So, we don't want to lose sight of that. But I have to say the 60-day survival, first of all, was far in excess of the survival of the first human heart transplant, and defied a lot of odds. A lot of people thought that the transplant would never come off of the extracorporeal membrane support system, would never be able to really beat on its own, would immediately be recognized as foreign. And so I think the fact that the heart did as well as it did demonstrated that there's a significant hope for this. And it's hard to know what would have happened if there wasn't the severe CMV infection that led to the diminution in the immunosuppression that then, seemed to invite in some of this rejection. So there's going to be a tremendous amount learned. As you can imagine, the heart is being carefully looked at in terms of what happened to the blood vessels, what happened to the cardiomyocytes themselves, what happened to the antibodies that were produced, how do they get cleared, how do they, interact with the medicines that were used. So, tremendous steps forward, and still a lot of work to do.
Okay.
Just to add quickly, it was really cool that it was the heart happening at the same time as the kidney. Xenotransplantation has been developing as well. Again, like I said earlier, sometimes we lag, so it's really exciting to see this approach, moving along so aggressively for the heart patients as well.
Where does stem cell treatment fall in this? All these different options,
studies.
yeah.
Our kidney folks are doing a lot with tolerance studies, with the stem cell transplant at the same time as the kidney transplant. So I think that's data that's still forthcoming, but I don't think we are making any moves on that on the heart transplant side yet.
Yeah, there's a stem cell approach in terms of the stem cell transplantation. There's also this concept of putting large number of stem cells into the heart. But as all of you know, when you go for your annual evaluations and you have the contrast, that's shot into the coronary arteries, that contrast passes through those coronary arteries very, very rapidly, right? And then gets disseminated to the rest of the body. Right. And so this concept of injecting stem cells into the coronary arteries and expecting that they're going to actually, gain a foothold inside the heart and to cause regeneration of the heart in a way that's going to not, incite electrical instability. Unfortunately, there was some early work with the stem cells in the cardiovascular space with heart failure that proved to be not valid. And so, unfortunately, there were not even signs really of viable cells left behind from some of the delivery methods. There's also been work done by one of our former physicians here, Roger Hajar, looking at evidence at using gene transfer methods. There's additional work being done with using like the substrate of the heart in terms of the lattice of the heart and trying to build those stem cells on top of the heart to try to cause regeneration of the heart. But the heart doesn't have the same level of plasticity as other organs do. And so it's not been simple to just, put more cells in and to expect a kind of a regenerative approach. But a lot of exciting work going on.
All right. Well, again, we're over time. I could stay for hours, but I'm sure everybody has better things to do. So thank you again from the bottom of our hearts for taking your time and getting us up to date on all that's going on over there. It all sounds good, and I can't wait to hear more. So I'll turn it back to Hamid and close us out. And again, thanks very much.
Yeah. Thank you. Truly, absolutely amazing, and just can't. I don't want to take up time. I'm just speechless at all that you guys do for us, and all that you're going to do for us and others like us in the future. So thank you. So just a couple things for resources that are available to you guys from through HeartBrothers. We have the patient assistance request form. You can go to our website. They're called PARFs. Sure, fill them out. That's if somebody, your patients, need some financial assistance. We'll try to do that. If there's any problems with them, reach out to Glenn, reach out to me, reach out to any of the HeartBrothers. We will try to resolve that. We have the HeartBrothers house, which then hopefully everybody's familiar with. 2 luxury apartments in Boston, in the area where I call it Hospital Alley, where you're in walking distance to most of the hospitals. So it's in the Back Bay and available to people on a first come first basis. We have a monthly virtual patient support group, second Thursday of every month at 6 p.m. Please join us. If you're a care provider, if you have a free time, we'd love to hear from you. If you're a patient, we want to hear your story. Maybe we can learn from each other. There's Team HeartBrothers. We're available for consultation on the phone, in person. If your spouse, caregiver, loved one wants to speak, our spouses and loved ones and caregivers are available to speak with you. If you go to our website, there's books we love. We share that. We have a therapist finder. The elephant in the room we do not talk about, especially with heart failure and heart transplant, is mental health. So we have an ability to help, some references for therapist finders. And we have other helpful website, apps, and brochures. It's all available at heartbrothers.org/resources. Again, thank you very much. And everybody have a fabulous evening. And Glenn, thank you to you. Great job.
No, thank you all.
Thanks a lot.
Thank you.
Bye-bye.
Bye-bye.